Hello, welcome to the APAP Podcast. My name is Ann Cartwright. I am a physician assistant, and I am on the board of APAP. I'm also chair of the sleep committee. So today we will be talking about sleep and cannabis, and I'm delighted to have Dr. Zoe Panchal with us. She is a clinical instructor and postdoctoral research fellow at University of Colorado Anschutz Medical Center, and she specializes in psychiatry. Her current research focuses on the intersection of cannabis use and sleep, and particularly the use of cannabis as a sleep aid. Welcome.
Thank you so much for having me.
All right, well, we're going to dig right in. So, first of all, what is cannabis? Can you briefly explain the differences between THC and CBD, especially as they relate to sleep?
Yes, absolutely. So cannabis is a plant, and that plant has actually over 400 different chemical compounds in it. And of those, about 80 are cannabinoids. And of those cannabinoids, the two best known and probably most important for clinicians to know about are THC, which is the short form for delta-9 tetrahydrocannabinol, and CBD, which is cannabidiol. And so THC is the psychoactive component of the cannabis plant. It's the one that causes euphoria and intoxication, and also the component that is primarily thought to be sedating. Whereas CBD is not psychoactive particularly, and so has fewer central effects that would be immediately noticeable to patients, although there's some thought that it may kind of maybe lessen some of the effects of THC or the problematic effects of it.
Yeah. And I know there is a wide variety of different cannabis products that are available on the market. When it comes to clinicians, what should we know about the different products that our patients might be using?
Yeah, that's a great question. So cannabis, it is a plant, like I mentioned, and so patients can smoke the plant or cannabis flower, right, which is kind of maybe the most typical way someone might think about using would be that. But then there's also different ways of using cannabis. So there are now concentrates which have a much higher concentration of THC and can be vaporized, and they tend to have somewhere closer to 80 or 90% THC, whereas flower would have a lower concentration, somewhere between 10 and 20% usually. And then there's edibles. So patients might be eating brownies or cookies or some other thing that has THC or CBD in it, and that's usually made by extracting the THC into oil or butter and then baking with it. And so it's important to know about all of these things because they have different kind of characteristics in terms of how they might be affecting patients. So edibles will have a longer onset of action and then will also last longer. Whereas concentrates or vaporized cannabis will have a very quick onset of action and then flower somewhere in between. And then you also are getting kind of the variety of potency, which is important in terms of how much it would be affecting them in terms of the psychoactive effects. So I think all of these things are important to understand and really to wrap your head around, okay, how is this particular patient using and how much and how is it likely to be affecting them? Is it likely to be affecting them during the night only, or is it likely to be having carryover effects into the day as well? Those kinds of things.
Yeah, and with all these different products available, labeling, is it reliable?
Yeah, that's a really good question. I think it's going to be variable from kind of dispensary to dispensary. So I think it also is worth noting that there are cannabis-derived or adjacent medications that I can talk about separately. But for cannabis that you would buy at a dispensary, it's really variable in terms of, whether the labeled amount of THC or CBD is actually what is in there. In terms of CBD products themselves, which are often sold as supplements in grocery stores and things like that, a number of recent studies have tested those, and they tend to have very variable amounts of CBD as compared to what's on the label, and sometimes even a little bit of THC when they're not supposed to. So I think, it kind of is similar to any unregulated product in that it may not be as reliable. Now, that being said, if for some reason patients are using a prescription, for example, there's a medication called dronabinol, which is essentially synthetic THC. Of course, that would be reliable in terms of what they're getting.
Right. Okay. So if you're seeing a patient in a sleep clinic and they say, yes, I'm using cannabis, marijuana, some sort of product, what is important as a clinician? What do we need to know? What do we need to ask?
Yeah, I think typically I tend to go into quite a bit of detail, almost in terms of taking like a little mini history on that. So like, how long have you been using it? How often are you using it? Is it just occasionally or is it every single night? What products are you using? Trying to get a sense of how potent they are. Are they only using maybe CBD gummies every once in a while? Maybe that's not something you need to then focus much on in your visit, but are they vaporizing THC concentrates nightly? Then that's likely to be impacting the clinical picture quite a bit more. And so getting a sense of, how big of a component of this person's clinical presentation is their cannabis use.
Yeah.
Yeah.
Okay. So for sleep apnea, what is evident surrounding sleep apnea, or surrounding cannabis for sleep apnea?
Yeah, that's interesting. So there's some really interesting preclinical work that suggested that cannabis might actually be beneficial for sleep apnea in terms of stabilizing respiratory patterns. There was, as far as I'm aware, only one study that was done in humans. It was a small study in 2018, and they did find some benefit to sleep apnea in that study. However, there have been a number of concerns about it, and so including smaller sample size and then concerns about whether patients had actually come off of their CPAP before enrolling in the study, which looked at dronabinol versus placebo for sleep apnea. So right now, the official position of the American Academy of Sleep Medicine is that cannabis should not be used for sleep apnea. And it will, there was this one small trial, but given its size and kind of some of the concerns about it right now, I don't think we really have evidence to suggest that it's beneficial, or at least not enough to take to clinic.
Yeah. Okay, now let's talk insomnia, because most patients, when we talk about cannabis and sleep, they're a lot of times using it for insomnia. So what is the evidence for cannabis and insomnia?
Yeah, so for that, I would split it into kind of THC-containing products versus CBD-only products. Most of the evidence base that people talk about is not particularly kind of the standard that we might hope for to guide clinical practice, because it's kind of sleep questions that have been built into other questionnaires, often open label studies. But there have been a couple randomized controlled trials. For CBD, there really hasn't been any signal that it's beneficial for insomnia if you're looking at it in a randomized controlled trial. For products that contain THC, there was a study out of Australia in 2021 of a proprietary compound that included both THC and CBD and did show some subjective benefit. So there might be a signal there. However, it was a crossover trial, which meant that participants got the the product and then they washed out and got placebo, or got placebo and then got the product. And there were some concerns about people potentially experiencing some withdrawal from the cannabis, and also about participants being able to tell what group they were in. The blinding was not successful. So unfortunately, although there was some initial thought that that might be helpful, I think more studies would be needed. And at this point, it's not clear that there's a huge benefit beyond kind of expectancy effects that we might see.
Okay. So patients often report subjective benefit from using cannabis for their sleep. Why do you think that is? What are they experiencing?
Yeah, I think there's probably a couple things. THC specifically can be sedating. So the first couple of times a patient might use cannabis, I think they may truly be experiencing perhaps some minor acute improvement to sleep. There's not a lot of evidence to suggest that that's sustained, though. So there may be some initial thought that there's an improvement. And then there's really huge expectancy effects around cannabis. So, well, I think clinicians have tended to be more hesitant in talking about cannabis because we really want to give the best evidence, right? And we don't have a big body of really good evidence around cannabis and sleep. I think that same degree of caution has not been true of dispensaries and people selling cannabis products. And so, a lot of patients or their friends or their neighbors, go down to a dispensary and we'll get like these very detailed recommendations on, yes, this strain will definitely improve your sleep, right? And so the studies looking at how people perceive cannabis and sleep show that most people expect that it would improve their sleep, and that can be powerful. The final, I think the final thing to note too is that cannabis withdrawal does worsen sleep acutely over a few weeks. So if someone is using regularly and then stops, their sleep will transiently worsen. And so then, of course, they might perceive that, oh, actually, cannabis does help my sleep because when I stop it, it's worse.
If they're a pretty heavy user or more of a long-term user, like someone's been doing it nightly for 5 years as opposed to 6 months, would the withdrawals last longer, or does that not really matter?
That's a really good question. I don't think we have data to answer that question. There have been a couple of studies on cannabis withdrawal and sleep among frequent users. Insomnia is one of the most commonly reported symptoms of cannabis withdrawal, along with actually, interestingly, vivid dreams. So if patients report vivid dreams on stopping, that is a known component of stopping cannabis. Generally speaking, sleep worsens acutely over 1 to 2 weeks, and then by a month out is back to baseline among people who have been using pretty frequently.
Are there, outside of sleep, what are other possible effects of cannabis withdrawal?
There's a lot of, can often be anxiety, irritability, anger, GI distress, so nausea, vomiting, appetite changes are the most common ones.
And if we're seeing a patient who is using cannabis for sleep and they decide to stop, is there anything we can do to help symptoms when they're in that acute insomnia withdrawal period, or do we just tell them to write it out?
Yeah, that's really hard. I often will ask people to taper their cannabis use. Now, that's not necessarily based on any trials. No one has examined that, but I think since, generally speaking, we taper insomnia medications, it's reasonable to see if a taper of cannabis would be more manageable for folks. If not, though, there actually have been a couple of clinical trials trying to look exactly at that, and none of them have been particularly successful. I think it would be reasonable, however, to offer someone a short-term prescription of a sleep aid in the meantime, maybe a month or so, to to help them out.
Yeah. Are there any concerns with patients who are using cannabis and sleep aids, like any interactions or medicines that you'd want to avoid?
Yes. So I think this is something that patients often don't realize, and even clinicians, is that cannabis is metabolized in the liver and does have some drug-drug interactions.
Hmm.
There's a couple of online pharmacologic interaction checkers, including, I believe, drugs.com and a couple others, that will allow you to check someone's prescriptions against cannabis. And so I think, you know, it's a reasonable thing to do and an important thing to counsel patients about, because I don't think that that's something that's on their radar.
Yeah. Are there specifically any sleep medications you would avoid in someone using cannabis?
Yeah, I don't think there's none that has kind of direct drug-drug interactions as you would think about in terms of like potentially changing the metabolism of one another. That's more so actually with some of the anticoagulants a concern. But for sleep aids, I think it's important to at least counsel patients that there can be kind of an additive or even synergistic effect, and so could increase next day drowsiness and things like that. And you just want to be careful in terms of too much sedation.
Gotcha. Okay. So if you have a patient that is a long-term cannabis user and they have no intention of stopping, they feel like it helps their sleep and they want to stay on it, what do we need to counsel patients on, if anything, with that long-term use?
Yeah, the things I think about talking to patients about are kind of the general risks of frequent cannabis use, which include developing cannabis use disorder. This is not very relevant in a typical sleep clinic population, but there is good evidence that early and prolonged use increases risk of psychotic disorders. We don't tend to see, patients in their early teens, but that is a risk. Cannabis hyperemesis syndrome, so people are recording vomiting and things like that, talking to them about that. And then those are kind of the main ones that I think about in terms of prolonged cannabis use. And patients seem to respond to that. I also think talking to people about if they're not feeling very good in the day, if they're not feeling very energetic, are they having kind of effects of the cannabis lasting throughout the day as well, which of course usually people want to sleep better, to feel better during the day, and so is important to keep track of.
Are there certain diagnostic criteria for cannabis use disorder?
Yeah, so at least for the DSM, it follows the same diagnostic criteria as any substance use disorder, and can be boiled down. I mean, you can always look it up in the DSM and things like that, but it can be basically boiled down to kind of loss of control over use and continued use despite harm to that person. And so all of the criteria kind of relate to those things. And I think, inability to stop using, even though someone wants to stop using, is a good signal that you should screen further. If someone's saying, I've been using cannabis for sleep, I would like to get off of it, but I just can't, that would be a signal to think about it.
Yeah. What about cognitive behavioral therapy for insomnia? So CBTI, where does that fit into management of an insomnia patient who is using or considering using cannabis for sleep?
Yeah, so if someone's considering using cannabis for sleep, I would absolutely refer them to CBTI and say, like, why don't you at least give this a whirl first, right? But if someone is using cannabis for sleep, actually, there has been at least one study showing that CBTI is effective for insomnia symptoms in those using cannabis, and can lead to at least slight reductions in cannabis use. So I would not consider it a contraindication to CBTI. Like, I definitely still would refer those folks to CBTI, and it might even help them cut down on use.
Yeah. Switching gears a little about, is there any evidence on cannabis use for PTSD and nightmares in the veteran population?
That is something that has less of a robust evidence base.
Interesting.
Cannabis can affect, the studies are mixed. So cannabis research has been really less extensive than other areas just because it has been Schedule 1 for so long that doing rigorous research has been hard, which is why so many of my answers are a little bit qualified here. So I don't think we have a good answer in terms of like large randomized controlled trials of this. Like I said, cannabis withdrawal is associated with vivid dreaming, and there's some suggestion that cannabis may impact sleep architecture in terms of latency to REM sleep and things like this. And so, it's not impossible that it would affect dreaming, but I don't think that we have the evidence to support using it clinically at this time.
Gotcha. One thing I just thought about, given all, when we're thinking about patients that are using this short term, but especially long term, with all the different preparations, presumably there's a lot of different substances and chemicals used in the processing. Is that a concern?
Yes, it can be. It's part of what makes cannabis so challenging to study is, right, if we're studying, say, alcohol, we know exactly what we're talking about. But cannabis, I think, as I mentioned at the beginning, the plant itself has over 400 different chemicals, and then you add in whatever is being used to extract the THC or this, that, and the other, and you have a lot of different layers. I think, there hasn't been anything that I'm aware of that's particularly a major concern at this point. But it's something to keep in mind that all cannabis products are not the same.
Yeah. Do you think, moving forward, dronabinol kind of synthetic formulations may ever have a place in sleep medicine?
I think if we get large randomized controlled trials that show that it's of a benefit, then it might, but I don't think that we have that evidence to date. And given that there are real risks of dronabinol as well, I think that we would need to really see that either dronabinol or, one of these proprietary products had a sustained benefit for sleep in larger trials than we've seen so far.
Yeah. So you and I are in a state where cannabis is legal, but that's not the same across the country. What do we need to think about from a documentation perspective? Because, most of us have federal DEA licenses. So are there considerations for what we put or don't put in the chart?
Well, I'm definitely not a legal expert, so I don't want to give any legal advice to anyone. I would say that, based on my understanding of the evidence at this point, there's not a reason that I can think of that a sleep medicine provider would be recommending cannabis to their patients at this point, because the evidence base just isn't there yet. And so unless, of course, for some reason you're doing that, there shouldn't really be a concern. I will sometimes document that, I recommended they stop, they're having a hard time. So we talked about this taper plan. I haven't had any trouble with that. And then, of course, just documenting what someone is doing shouldn't affect your license, or that you recommended XYZ different course of action also shouldn't affect your license, I wouldn't think.
Yeah. So you're a little bit unique in that this is your area of interest and expertise. So if a patient comes to you for sleep and they ask about cannabis, you can have a very lengthy, in-depth conversation. Most of us aren't going to do that. So let's say I am seeing a patient and I have a couple of minutes and they're talking about they can't sleep and they say, my neighbor next door started smoking a little before they went to bed and they said it helps. Do you think I should try it? What would you say in, a minute or two?
Yeah. So whenever I get that question and it's not the main focus of a visit, I'll say, generally, we don't recommend cannabis use for sleep. It hasn't been shown to have benefits as of this time, and there are some risks. And then I'll kind of go through whatever risks I think might be most relevant to them, perhaps drug-drug interactions, perhaps concerns about cannabis use disorder, perhaps concerns about daytime fatigue, whatever I think might be relevant to their situation and that they should be aware of. And so I just keep it pretty brief and succinct that right now we don't have the evidence to show that it's beneficial long-term, and you don't recommend it.
And quicks, again, 1 minute or less, if you have a patient that uses cannabis and you think they should stop and they say, I don't want to, it helps me sleep, what would you say?
Yeah, so that's where I kind of revert to my psychiatry training, I think, in terms of thinking about principles of motivational interviewing and then also harm reduction. So I'm thinking about, exploring with them. Again, if you really only have 1 minute, I would use that minute to just make sure that you told them why you don't think they should use cannabis, right? They may not agree with you, but I do think as clinicians, it's our responsibility to give people at least the reasoning behind our recommendation. So I might say, this is the reason I understand that you feel like it's helping you sleep. These are the reasons I worry about it for you. We can circle back to it later. And you don't have to get into a big thing. Every once in a while, you can check in with them about it, assess, whether they perceive any potential downsides, daytime fatigue, anything like that. And then if you can get them to use even less frequently or less potent, so if they're using concentrates, using flower instead, if they're using every single night, or there are some nights that they might be able to not use, that kind of thing.
Yeah. So being in a sleep clinic, I have a lot of people come because of daytime sleepiness. That is their primary complaint, is that they're very sleepy. And in taking a history, I find out that they are using cannabis, and often a lot. So I may have patients that may do it 3, 4, 5 times a day. And I say, well, that could be contributing to your sleepiness. And they were like, oh, no, absolutely not. Do you find that people are resistant to the idea that it could be contributing? And how would you handle that conversation?
Yeah, I think that's a point well taken. So cannabis has some of the lowest rates of treatment seeking of any substance. People, it's very low rates that people perceive it as a problem or seek treatment for their use. Generally speaking, I try to avoid getting into some kind of argument with people about their cannabis use. If you say, could it be possible that might be contributing? And they're like, absolutely not. Then perhaps you can focus on something else, but keep on circling back to it. I personally do set kind of boundaries for myself in terms of what I'm willing to do. So, if someone's reporting daytime sleepiness and they're asking me for a stimulant for their daytime sleepiness, and I know they're using cannabis heavily, I would need that to see them to reduce or stop use before I would prescribe a stimulant. Other people may think that differently. This is specifically, I'm talking about my personal practice with regards to daytime sleepiness.
Right.
And so I think it depends. And you can also always have the conversation of approaching it. Sometimes people will respond to approaching it as an experiment, like our personal experiment. What do you think would happen if you tried stopping for 2 months and then we can see? And it can be our experiment rather than coming at it as like, you definitely have the answer and they're wrong, but we're going to experiment and see if it.
Yeah. What about people having MSLT? So they're tired. You think they have narcolepsy or whatever, and so you're sending them for the MSLT. We do urine drug testing that morning.
Mhm.
And so, I do counsel patients, you need to be off of it and please don't start if you're not using it. What time frame do you tell people to stop ahead of time if they're a chronic user?
Yeah, at least a month. And depending how heavily they're using, it could be up to 2 or 3 months. Cannabis is lipophilic. And so if people are using consistently over long periods of time, or rather THC, the cannabinoids themselves are lipophilic. So if they're using over long periods of time, there's probably a decent amount of THC in their adipose tissue that will then kind of slowly come out of their body over a month or two. So if they want to be sure not to have problems with the MSLT, at least a month.
Okay, but maybe 2 or 3.
Yeah.
If you have a chronic cannabis user, and you are thinking it may take a little longer for it to come out of their system, do you think there's it takes a long time at most institutions to get in for the MSLT. Do you think there's any benefit in doing a urine drug screen prior to the like prior to even coming in and starting the test to make sure it's out of their system before going through all that?
Oh, that's a reasonable question. I mean, if they've actually stopped and it's actually been 3 months after they're stopping, I would think that it would be extremely rare that it would show up on the day of the MSLT. It's also true that like the urine dipsticks have a reasonably higher cutoff for what they'll detect. So there could be a little bit left and still not be detected. So I think it depends on the patient and how concerned they are. But I don't think as a practice I would have people do it before routinely.
Okay. Anything else, being an expert in cannabis and sleep, for those of us who are not, any pearls of advice, pieces of wisdom, anything else?
I would say the biggest thing would be just don't be afraid to ask people about their use and the details and talk to them about it. The more patients you talk to about their cannabis use and understand what they're doing, and try and support them with that, the more you'll learn about it and the more you'll have a sense of your own clinical practice around it.
Do you think patients are pretty truthful reporters of their cannabis use?
I have no
alcohol,
idea.
whatever patient, however much alcohol a patient says they're taking, double it.
Right.
Do we find that with cannabis too?
I don't know. I would say a lot of people don't seem to have a problem telling me if I ask them. I do try and use the word cannabis and not marijuana just because it's a little more scientifically accurate, and people, I think, experience that as you being a little bit more neutral or just wanting to know rather than being judgmental. And then I think it may very well depend somewhat on the legalization status. I think where we live, with cannabis being fully legal, at least at the state level, people aren't super concerned about talking about it. That might be different in a different legal environment. We do know that people seem to use cannabis for sleep more in legal environments. So that's something else. How relevant this may be to people may depend on the legalization environment they're living in.
Yeah. One other question I just thought of, has there been any research or looking into using cannabis for other sleep disorders like restless legs?
Yeah, great question. There've been some very, very, very preliminary studies. Nothing has really panned out so far, but it wouldn't surprise me if people look into it, and we get trials coming out in the coming years.
Wonderful. Well, Dr. Ponchal, as always, thank you so much for your time. This has been the APAP Podcast. Be sure to claim your CME credits. There is going to be a link in the show notes and a link on the APAP website as well. If you are interested in sleep, you could consider joining the sleep committee within APAP. If you're interested, send an email to info@pulmapp.com. Everyone, enjoy the rest of your day.